Okay, we'll get started here. Thanks everybody for coming this evening. So we're looking forward to sharing some practical tips about managing migraine, and also to, let me grab the slide advance so I have a cue. Talk a little bit about some new ideas about ways to manage migraine patients, including both acute and preventive therapies. And then we'll be talking about some of the exciting new therapies that are on the horizon. So I can advance here. Just to let you know, this activity is supported by an educational grant from Lilly. And for further information, if you want to contact Lilly regarding the website, you can go to the website. It's also supported by an educational grant from Teva. And my name's Andrew Charles. I'm a professor of neurology at UCLA, where I've been for now 37 years. Did med school there and have been there pretty much ever since. A multidisciplinary migraine program there. And we're excited about the things that are going on in our field. And this is Dr. Grace Ford. She can tell you about herself.
I am Director of Neurological Services at North American Partners in Pain Management. I'm in Long Island, New York, and I've been there for the past 14 years.
A couple of oldsters. Okay, so learning objective number 1, apply knowledge of clinical features, symptoms, and key diagnostic criteria in the differential diagnosis of migraine. Number 2, assess safety and efficacy data supporting the role of agents that target CGRP, which is calcitonin gene-related peptide, in the prevention and management of migraine. Employ a patient-centered approach to the care of patients with migraine in order to improve outcomes, patient satisfaction, and treatment adherence. And so then we're actually now going to start with some patient-guided content. And so what you'll be hearing is some audio files from individual patients expressing their own issues, needs, and concerns with regard to migraine. This is part of an effort to leverage social media to express patients' voice in healthcare. And this represents feedback from social media communities of thousands of people with migraine. So here's the first patient quote. I think you're up next. We have the audio.
They also affect my quality of life each day, because sometimes the days leading up to and after a migraine, I'm pretty much out of commission, and the day of the migraine, I definitely can't do that much. So sometimes I'll have to cancel work, meetings, or social engagements.
I have been completely sidelined from my career due to chronic migraine. I was once working more than full-time while raising 2 young children. My episodic migraines turned chronic, and I had to seek disability.
So these are things we hear every day in our practice, day in and day out. I'm sure you do as well. What you see here is the real effect that migraine has on people's lives, and these quotes are good examples of the kind of devastating consequences that migraine can have, both socially and professionally. So I think we're going to start with Grace.
So migraine is highly prevalent, but receives very little attention as a public health issue. And we see this all the time. Patients, it takes sometimes, 2, 3, 5 years before patients are diagnosed correctly with migraines. So it usually begins in childhood, but it can increase between ages 10 to 14, usually when kids are going through puberty. And it continues to increase until ages 35 to 39. It is 2 to 3 times more prevalent in women, and this is significant because during the peak years, 35 to 39, or even in their 20s, women have jobs, they have childcare responsibilities, so the disability that is associated with this disease is really amazing because, so many patients are affected. The prevalence at its peak is greater than 25% in women, and as many as 1 in 25 women may have chronic migraines. That means patients have migraines more than 15 days a month in this country. This is a very important slide. It shows years lived with disability, and the slide on the left-hand side of the screen shows that some of the comorbid conditions with migraines. So you can see here neck pain is definitely associated with it a lot of the times. Medication overuse, headaches. We try to get patients not to overuse medications because this is a real problem. Depression, anxiety, these are also very comorbid conditions that we see a lot. The slide on the right-hand side is a busy slide, but the take-home message is that migraines is number 2 in disability, and it's only secondary to lower back pain. And that is something that people really don't think about. We know lower back pain is very common and very prevalent, but migraines is right up there, and it's more common and prevalent than a lot of other chronic illnesses. So the impact of migraine on family life. This is the CAMEO study, and CAMEO stands for Chronic Migraine Epidemiology and Outcomes Study. So patients with migraine report higher family burden due to the migraine than their spouse or partner. A lot of people, when you have migraines, it's just not the patient themselves that are affected, but everyone in the family is affected. There's reduced participation in family activities due to the migraine, reported more than once a month, and that was amount 48 to 57% of migraineurs, depending on the frequency of the migraine. And this is something that, patients, they miss Little League games, they miss their kids' soccer practice, the ballet, or what have you, which is very significant. Many with migraines, 24 to 40%, and episodic migraines, and patients with chronic migraines, close to 44%, perceive that their spouse or partner do not believe the severity or the impact of the headaches. Most of the times, people who do not have migraines, they literally just don't get it. It's hard for them to understand that something like a headache, quote unquote, can be so disabling. And we have to tell them it's not just a headache. And that is something that we have to drive home. Sometimes my patients would bring their spouses in so that I can explain to them, to the severity of the migraine attacks. 1/3 of migraineurs worry about long-term financial security for themselves and their families because of the headaches. And many felt there would be better parents without the headaches. The typical mother, because it's usually women, lying on the sofa, quiet, dark. The kids can't run around, make noise because of the headaches. And this really impacts the child. They remember this, and they really consider themselves not good parents because of the headaches.
Okay, so I'm going to talk a little bit about diagnosing migraine. And we'll start with the case. So Julie is a 32-year-old mother of 2 young children, 15 months and 3 years. Whoops. Pain is bilateral and maxillary in location. So here and a little bit frontal, constant, not throbbing, but she also has commonly has pain down the back of her neck. And she wonders whether this might be weather or sinus related. She says she's always been able to tell when the barometric pressure changes. So in Los Angeles, we have the Santa Ana wind conditions. That's our big barometric pressure change. And that often migraine patients identify that as a trigger for their migraines. The past 2 to 3 times, she's had to leave work, not only because of headache and often nausea, but she can't concentrate and focus on her work and has made some mistakes that she would rarely make. She's managed with over-the-counter naproxen sodium, but lately it hasn't been effective, and she's concerned about taking too much of it and ulcer complications. She made an appointment with an ophthalmologist because she's had some blurring of vision that she's experienced. With 2 small children and working full-time, she's already not sleeping much and fatigued. Adding in that is the headaches are really getting her down, and she confesses that she's not great to be around some days. And she shares that she experienced some depressive episodes and is currently taking 100 milligrams of sertraline daily. Also notice she has a BMI of 32. So, common story, and we'll start here now with the first question in the game. So, what is the best option to take as next as part of the examination? Recommend that she begin to take butalbital complex, fiorinal or Fioricet. Order a CT scan to investigate the neck pain. Order a CT or MRI scan to investigate headache, vision, and cognitive complaints. Palpate the head and arteries and check balance, or do a funduscopic exam. I was hoping for Taylor Swift. So, next question. How confident are you in your answer? Not confident, somewhat confident, confident, or very confident? Okay, so we've got a nice mix there. We've got 35% saying palpate the head, arteries, and check balance, which is not necessarily a bad answer. Certainly in an older individual, we'd be interested in checking arteries to see if they have temporal arteritis. And checking balance as part of a neurological exam would certainly be not a bad idea. Palpating the head is something that one might want to do to look for trigger points and other areas of tenderness. But the correct answer is actually conduct a funduscopic exam. And why you'd want to do that is because this is a woman who's overweight. She's got blurry vision. So whenever that's the case, you will want to rule out a secondary cause of headache, which is intracranial hypertension, otherwise known as pseudotumor cerebri. So having a look at the fundi would be a good idea in this person, particularly because the history, although answer 4 isn't that bad, I think it's not an unreasonable one. Just addressing the other ones quickly. So recommend that she begin taking butalbital. This is something that neurologists don't like at all. As Dr. Ford was saying earlier, it gives her tremors when she thinks about this because, so what many people don't know is that this drug has been taken off the market in Europe because it's so well known to cause medication overuse headache. It's insidiously dependence producing, and people get stuck on it and can't get off of it, and it ends up making their headache worse with time. So butalbital is really something that neurologists in general are not fans of. The neck pain's common with different kinds of headaches, but particularly with migraine, and generally speaking, there's no pathology in the cervical spine that warrants imaging. And finally, again, even though she has a variety of complaints, not just headache, but vision and cognitive complaints, those are all part and parcel of migraine, as we'll be talking about, and so that's not necessarily a reason to have to do imaging in somebody like this.
I just want to add some
Sure.
historical perspective on number 1, the fiorinal and the Fioricet. I call it the F word. It's, I trained at Montefiore in the Bronx in New York, and fiorinal and Fioricet was brought to the market from the studies at Montefiore. And Montefiore, they no longer prescribe it. Seymour Solomon, who was instrumental in this, he is in his 90s, still practicing half day a week. He no longer, and he really rails against it because of the incidence of rebound headache with fiorinal and Fioricet. So I usually tell patients I can't spell it, and if I can't spell it, I can't write for it.
Okay, so the diagnostic challenges, part of the challenge is that people think about migraine as only a terrible headache, and they often think about it as a one-sided headache. But it can be bilateral. I would say probably, I don't know about your practice, but the majority of my patients have bilateral pain. It may start on one side, but it eventually becomes bilateral. And it can also be, it doesn't have to be throbbing, it can be constant in quality, it can actually be moderate in severity with other symptoms more important. And then there's this issue of sinus disease. So many patients are totally convinced that they have so-called sinus headache. But this is another historical perspective. The diagnosis of sinus headache didn't even exist in our medical lexicon until it was introduced by the manufacturers of Triptan, the decongestant. They created this diagnosis. And if you look at advertising on the TV, you'll see all kinds of ads really going after migraine patients with sinus medications. So this is another misdiagnosis that is really common and something that we have to address directly with our patients. So attention type headache, again, sinus headache. I even hate to use that because I don't believe such a thing exists. Certainly people have sinusitis, but sinus headache is not really a thing. So the other key part is that migraine is very heterogeneous. It can change over time with different attacks. There can be some shared risk factors and triggers. So the menstrual period, skipped meals, irregular sleep can trigger attention type headache. And then comorbid conditions like depression and anxiety can complicate the diagnosis as well. So here's an interesting point. Whenever I see a patient, one of the first things we do is look at their med list. What's interesting is that very often they haven't addressed medications that can be making migraine worse. So opioids, there's a lot of attention to opioids these days, and it's clear that opioids like butalbital make migraine worse. Oral contraceptives and hormone replacement therapy. So these are big ones. Many, many women who are on oral contraceptives, they are an exacerbating factor for their migraine. It's less of a problem now that we're using much lower doses of estrogen, but still, even with low-dose estrogen preparations, for some women, this is a big issue, and they simply can't manage their migraine until the oral contraceptive issue is addressed. The SSRIs, this is controversial, but in my experience, SSRIs like fluoxetine or sertraline are ones that really can exacerbate migraine. And this is one that's a problem because many migraine patients have comorbid depression. And this is kind of an evidence-free zone. We don't really have clear evidence for this yet, but my general impression is that SNRIs like venlafaxine or duloxetine are preferable for patients with migraine and may also go after comorbid fibromyalgia as well. And so when we see a patient not doing well on an SSRI, we always think about switching to a different agent. Decongestants we mentioned. The interesting other one is proton pump inhibitors. So many people get put on PPIs and they just stay on them for years and years and years, often because they have a rebound when they stop. They have rebound reflux symptoms when they try and stop. But there's growing evidence that the PPIs have central nervous system effects. And you've probably heard some about this at this meeting, but we also have patients for whom we're convinced that they're kicking up their migraine. And unfortunately also some of the bone density medications may be making migraine worse. So whenever we see a patient, look at the med list, especially if they started doing worse at a given time, ask if they started a new medication at that point.
I just want to make a point.
Yeah,
on the oral
sure.
contraceptives, I actually, in terms of my practice, I see the oral contraceptives can sometimes make migraines a little bit better. In menstrual patients with true menstrual migraines, if, the problem is that they fluctuate in terms of the estrogen levels. So if you do continuous oral contraceptives where you don't give the placebo pill, I find patients do better when they're not cycling every 28 or so days. So sometimes oral contraceptives can help with the migraines with true menstrual migraine patients.
Certainly agree with that, yeah. Don't mean to suggest that, and many women, obviously, we're needing to use them, or really they're treatments of choice, and so the issue is really working around it, and I totally agree that finding the lowest dose that works and using it continuously of estrogen is the way to go. So tension and sinus headaches. So tension headache for me is basically a diagnosis of exclusion. Interestingly, in my practice, I almost never see patients with tension type headache because I diagnose almost all of them with migraine. So if the pericranial tenderness is common, but you very commonly get pericranial tenderness in migraine, so that's not really a differentiating feature. It's usually milder, but the key is it doesn't have the associated features. So it doesn't have nausea, it doesn't have light or sound sensitivity, not generally worse with activity, and generally is not as disabling. So again, maybe it's because I have a tertiary referral practice, but we just don't see those patients. And then again, sinus headache, I hate to use that term, but it's basically pain related to sinusitis that's either acute or chronic. But interestingly, they've done now 2 or 3 studies where they've shown that minor changes in sinuses like mucosal thickening or retention cysts basically have very little to do with exacerbating headache. So that pathology, may be causing other symptoms, but generally speaking, it's not a big issue with headache. So this is a timeline of a migraine attack. Complicated slide here, but just to point out that a migraine attack is not just headache, but includes multiple phases. What we call the premonitory or prodrome phase, where people have yawning, interestingly polyuria. They often are urinating frequently. And then they'll have neck pain, fatigue, mood change, and light and sound sensitivity well before headache begins, hours before headache begins in some cases. Then some people have the aura, which is defined as either vision change, language change, sensory change, and cognitive dysfunction or brainstem symptoms, which this patient had some of. Then comes the headache, and then patients may develop this cutaneous allodynia where normal touch becomes uncomfortable. And then following the headache, people may have this hangover, this residual fatigue or mood change, or just not feeling well, even though the headache is actually gone. So the cool thing is that now we have functional imaging studies that basically show different parts of the brain lighting up during each one of these phases of the attack. So you can see changes in areas of the brain like the hypothalamus, the brainstem, the cortex corresponding with these different symptoms. And physiologically, you can do different sorts of EEG and evoked potential studies that show changes in neurophysiology. There's changes in chemistry. And then also what's been recently demonstrated, which we'll talk about, is that there's this release of these neuropeptides, CGRP and PACAP, which are looking like from the clinical trials playing an absolutely key role in migraine.
I just want to make a comment on that slide.
Yep,
That's a really interesting slide. As someone who also do pain management, the cutaneous allodynia is very important. A lot of patients tell you my hair hurts. And for someone who really don't see migraine patients, when someone tells you your hair hurts, it sounds like, maybe she's kind of crazy. But literally the hair hurts, and that is what cutaneous allodynia is. It means that the migraines has now been to the second order neurons. So I almost like to make the analogy, the patients are behind the 8th ball at that point, because it's very difficult now to treat the migraines because the patients have allowed the migraine to progress to a point now where it's so difficult to treat that have this cutaneous allodynia.
That's right. Good point. Okay, so I guess this is still me. So chronic migraine is headache occurring on more than 15 days a month. This is kind of a misnomer because chronic usually refers to how long you've had it. But the definition chronic migraine was actually developed by the drug company Allergan as a way of justifying the indication for Botox. And so they basically came up with this definition that chronic migraine is headache occurring on 15 or more days a month. And then there's this kind of parsing out of the symptoms. So only on 8 days per month, it has to have features of migraine. And this is something that actually reflects the observation that we have with many of our patients, that as their migraine becomes more and more frequent, it loses some of the features, and they may have, some days where they say this is more just like a headache, and you'd call it a tension type headache, and then they have spikes in pain with nausea and light and sound sensitivity, which we then call migraine. But to define something as chronic migraine, only 8 of the 15 days have to have migrainous features. And very often chronic migraine is associated with medication overuse. Many people, if they withdraw the acutely used medication, will revert to episodic migraine. This is also, again, where a headache diary really helps to identify. And the other interesting thing is, I mean, you often will ask patients how many migraine attacks they have per month, and they'll say, well, maybe 2 or 3. But then you ask them, how many days of the month are you headache-free? And they'll say never. And so that's the interesting kind of issue with diagnosing chronic migraine, is that you get people who identify only their severe headaches, but when you really dig into it, they're having headache on a daily basis. So here's the ICHD-3 criteria. I'm not really going to get into those, except just to say that there's a lot of, this is for migraine with aura, and the key feature in terms of distinguishing aura from stroke is that it starts gradually, it spreads gradually, and it's completely reversible, even if it's not accompanied by headache. But one of the issues that we run into with the ICHD-3, and so that's the International Classification of Headache Disorders, which is kind of like the DSM for psychiatry. And just to be clear, it's a bunch of old, mostly men, sitting around a table saying, this is what we think migraine is. I'm on the committee, so I know what I'm talking about. But it really is not something that that necessarily is set in stone, and there's a lot of challenges to it. I think that really the point is that this gives us a common language, so that when we say somebody has migraine with aura, we're all on the same page. But it may not necessarily be that practically useful in your clinical practice. So the ID migraine is a much simpler one. This was developed by Richard Lipton at Albert Einstein, and it's 3 questions. Over the last 3 months, have you limited your activities on at least 1 day because of your headache? Does light bother you when you have a headache? Do you get sick to your stomach or nauseated with your headache? And if the answer to any 2 out of those 3 questions is yes, then with very good sensitivity and specificity, that's migraine. So what's interesting when you look at those questions is there's nothing about the severity or the quality of the pain there. What there is questions about disability, light sensitivity, and nausea. And those are things that really set migraine apart. The associated symptoms and the disability associated with it are what really make us diagnose migraine in clinical practice. And so this ID migraine is a nice way to think about it as an easy set of questions that you can ask in your own practice. So turn it over to Grace again for strategies for migraine prevention.
So we're going to talk about Julie some more. So Julie was prescribed a triptan to manage her acute migraine attacks, and it was effective for 2 years. Julie's here today because for the past 6 months, her migraines have gotten worse, more frequent, more severe, they're lasting longer, and sometimes up to 2 days. She's using her triptan 3 to 4 times per week, but admits that sometimes she's tried to hold off, hoping that the headaches will subside. Her visual disturbance is getting more pronounced. Migraines have interrupted her exercise routine, and she's gained 10 pounds, admitting that she's not eating as healthy as she should. So game on. Next slide. I guess this is it. Game is on. Oh, so leadership board. So, live streaming. So navy blue, 28 points. The pink, hot pink is 33. Yellow, 26. And the blue, 30 points. Go team pink. Yes. All right? Next. Okay. So what would be your next course of action with Julie? Stop a triptan because it is contraindicated when using sertraline? Would you consider having her add a behavioral management strategy to her regimen, such as relaxation techniques, cognitive behavioral therapy, or EMG biofeedback? Would you consider discontinuing her sertraline? Or would you ask her to revisit her headache diary for the next month to see what triggers may be contributing to her headaches?
not the next course? Which would not?
I'm sorry, which would not be your next course of action with Julie? Correction. Oh, start it over again. Not, the important word there. How confident are you in your answer? Not confident? Somewhat confident, confident, or very confident? So 48% of you decided to stop a triptan because it is contraindicated when using sertraline. Not.
That's right.
I keep saying confident. So not.
Good.
Okay, excellent. That is the correct answer, even though I confused you over and over again. So that is, there's a big hoopla with using sertraline or any of the SSRIs and the triptans. Us neurologists, we really don't have a problem with it, and it's a theoretical contraindication, but the pharmacists, usually I receive a lot of phone calls if I prescribe the patient a triptan and then a low dose of whatever SSRIs they're on, because we're all very anxious in this country, so everybody's on an SSRI, and the pharmacist will call you because, the patient is on both. But I usually tell them it's fine, What is the problem is when they tell the patients that this is something that is dangerous. I don't know if you get those calls also.
Yeah, and just the interesting point here is, first of all, the case series in which they made this recommendation, if you go back and look at it, the triptans had nothing to do with the serotonin syndrome, number one. Number two, scientifically it doesn't make any sense at all, because serotonin syndrome is basically caused by activation of the 5-HT2 subtype of serotonin receptor, and the triptans are highly selective for the 5-HT1 subtype of receptor. So this is something that drives us neurologists crazy, but and how it got out there is sort of, it's an example of policies that basically get put forward without talking to the people who actually know what they're doing.
So the, number two, you always want to do cognitive behavioral therapy and biofeedback. So that is not a correct answer for that reason. Consider discontinuing sertraline. Some people would consider doing that. I know Andrew was saying that he has realized that maybe sertraline and some SSRIs can maybe make patients' migraines worse. I really haven't noticed that, but I do know that it doesn't really help the migraines. I think secondarily, some people believe it helps because it helps treat anxiety. It's a very good anti-anxiety medication, and patients with migraines tend to be very anxious. When am I going to get the next headache? Can I plan what I need to do, whatever? So on that level, it maybe helps, but strictly for treating migraines, it's not one of the options that we choose. Did you want to comment on anything else?
Yeah, I agree with you, I think, and certainly if a patient says, sertraline changed my life, I'm no longer depressed, that's certainly something where, leave it alone. You're not going to rock the boat in somebody who's had a positive benefit. But more typically, the patients we see are ones who they're still having a lot of headache and they're still depressed. And so this would certainly be, again, a situation where you would evaluate whether the sertraline is having its desired effect, number one. Number two, is it actually having any adverse effect in terms of migraine frequency? And number three, think about a different medication if, in fact, somebody needs to be switched to a different antidepressant.
And at that time, an SNRI might be the better choice,
right,
because it can do both the anxiety, depression, and the migraines. Next slide. So Julie works on identifying triggers and implementing behavioral management, but does not find relief. What is your best next step? Switch her medication, EMG biofeedback, initiate a preventative strategy, recommend that she try acupuncture, or recommend that she supplement with an opioid. What is the next best step? How confident are you in your answer? Not confident, somewhat confident, confident, or very confident. So we would all initiate almost preventative therapy. A few of you would switch her medication, and the rest is smattering. This is what I would most probably do, to definitely start on preventative medication. It seems like she's not doing very well on what she's on. She's implemented some behavioral management, which is critical in terms of treating migraines, lifestyle changes, behavioral management. But again, it's not, cutting the mustard, as we say, so we do have to move on to preventative strategies for Julie. So this is, Julie's going to tell you some more information.
Audio?
The audio?
I think providers will talk about pros and cons. So pros, you have less migraine days, less frequency, but also the intensity is less. They tell you that it's a better life quality when you have these treatments that work, preventative treatments, and obviously that is extremely appealing. When they talk about cons, they talk about side effects, talk about long-term effects, and they talk about especially tolerance buildup.
So that was some of the pros and cons of preventive medication from a patient's perspective. So when to consider preventive medication for migraines? The decision to initiate preventative strategies should be based on attack frequency. Pretty much most of us go by the recommendation of greater than 1 week or 4 days per month. However, if the patient is having, say, 1 or 2 headaches a month, but each headache lasts 2 or 3 days, then I would go by headache days a month of disability. And disability is my driving force for preventative medication. Because even if the patient is having 1 headache a month, and that headache is lasting 3 days, and there are 3 days where that patient is unable to function, I believe that that patient should be on preventative medication. Responsiveness to medication for acute migraines. If the acute medication is working, despite all the available medications we have currently on the market, again, that patient is a candidate for preventative medication. And coexistent conditions. Do you have any recommendations, Evan?
No, just again, if there are very disabling symptoms. So for some people with, for example, hemiplegic migraine, where they become weak on one side of their body, even if they only have 2 days of that a month, it's so disabling that they're okay with taking a preventive medication to stop it.
Absolutely. So these are some of the preventative medications for migraines. The ones that are highlighted in red are the ones that are FDA approved for the treatment of migraines. But again, we use a lot of different medications for a lot of different classes, but just the ones that are in red that are FDA approved for the treatment of migraines. Some are better than others depending on what comorbid conditions the patient is experiencing. If the patient has a lot of anxiety, then maybe one might want to do, or maybe some tachycardia, maybe propranolol might be better for that patient. If the patient is obese, because obesity is one of the causes in terms of transforming episodic migraines to chronic migraines, maybe topiramate might be for that patient, and maybe you may not think more of divalproic sodium because there's some weight gain with divalproic sodium. So if the patient is obese, maybe you want to do topiramate instead. So it all depends on what comorbid conditions the patient has, might lead you down one path versus the other. Onabotulinum toxin A, again, is indicated for chronic migraines. It's the only medication that is actually for chronic migraines, and topiramate also. Do you have any?
Yeah, no, just some interesting points. You may not recognize that candesartan is on the list now. So there are 2 well-designed placebo-controlled studies of candesartan as a preventive therapy for migraine, and it's now available generically. Generally speaking, I would say that's probably the best tolerated on the list, and so that's one that we often go to if we're worried about adverse effects. The second thing, there's one other one that's actually now FDA approved for prevention, which is transcranial magnetic stimulation, just got recently approved. This is the handheld TMS device. So completely agree that there's not any single one that's really rises to the top of the list, except onabotulinum toxin for chronic migraine. It really is based on comorbidities and the concern with adverse effects. I would just point out that the reference down there at the bottom is not the correct one. So I tried to summarize all of this in that paper that I did last year in the New England Journal. So if you want a table that's got all of this stuff on there, you can check that out.
What are your thoughts about Cephally? I'm a migraine sufferer myself, and I tried Cephally, and I hate to admit it, I did not have a migraine, but I got one when I had the Cephally on. So I don't know, that's just me. But
yeah, so the Cephally device, I don't know if you have seen it. It's a Star Trek looking thing. It's a headband that you put on that does supraorbital nerve stimulation. It was originally indicated as a preventive therapy. It's now actually has an indication as an acute treatment. But basically, I agree with you, many patients find it uncomfortable and difficult to tolerate. For those who do tolerate it, some like it. The nice thing about Cephally is it does have a money-back guarantee, so that if you don't like it, you can send it back, which is not true of some of the other approaches. So I'm certainly not going to give it a ringing endorsement, but given that it's not a medication, there are situations like pregnant women, for example, where we'll give that a shot.
it's good to know I can get my money back.
Okay, so talking about emerging therapies. So there's some questions coming in about these. I hope I'll answer some of these questions as we talk. But by the way, we're going to have plenty of time for individual questions at the end. So put those in whenever you think about them. All right, so this is another complicated slide. Sorry, I like colorful slides. This one is from this Lancet Neurology. It's just making the point that I think about migraine as kind of a funnel or a migraine attack. So up at the top, you have genes, you have environment, you have hormones, drugs, metabolism, and these are all different in different patients. So there's a different mix of the factors up there at the top of the funnel. And then you get these brain and changes and different sorts of areas of the brain becoming activated. And then now we're thinking that towards the bottom of the funnel as a common final pathway is the release of these substances like CGRP and PACAP, which is pituitary adenylate cyclase activating peptide. And by the way, these are peptides that have multiple functions in the body, but one important one is causing inflammation and pain. And so that we're understanding that release of these peptides is important. And then finally down at the bottom of the funnel, depending on the patient's state, whether they've eaten, what genes they have, what drugs are on, then that will dictate what their symptoms are. And that may vary from attack to attack or from person to person quite considerably. So what's the evidence for this CGRP in migraine? Well, the first evidence came back in around 1990 when Peter Godesby and Lars Edfinson showed that if you take jugular blood of patients having a migraine, and this was something that they were doing, I think, in Australia. I don't think we would get that approved here. But at any rate, they measured elevated levels of CGRP in patients having migraine attacks and actually also cluster headache attacks. And what they showed then was that if you treat the migraine with sumatriptan, the CGRP levels go back down. So there's this high increased level of CGRP in the blood during migraine. Next, they found that if you give CGRP intravenously to a migraine patient, it will evoke a migraine attack. So pretty reliably, if you give migraine patients CGRP, a couple of hours later, a migraine attack will start. There have been also now a couple of reports showing that in patients with chronic migraine, CGRP levels are chronically elevated. And next, there's evidence that these small molecule CGRP receptor antagonists, typical drugs that we use, which are small molecules going after receptor, those effectively aborted migraine attacks. So why didn't they bring those forward? Well, they did. Merck basically had one that was just about to be brought onto the market, and it basically was shown to have significant liver toxicity. And so they pulled it just really literally months before they were planning to release it. So then they got the idea, well, and taking a page out of the rheumatoid arthritis book or the cancer book, why don't we make antibodies to CGRP or to its receptor as a much more specific way of going after this target that doesn't have the kind of off-target or metabolism effects that the small molecule drugs do. And so that's what's generating enormous excitement in the field right now, is the effect of these antibody therapies, which I'll tell you about a little bit. So there's 4 companies making these. I'll just name the companies, even though it's not on the slide. So it's Lilly, Alder, Teva, and Amgen. So they're kind of in alphabetical order. So eptinezumab is the first one. That's the Alder product. It's given intravenously, interestingly, once every 3 months. And they basically, I should say so I don't have to repeat it, all of these drugs have now completed phase 3 studies for both episodic and chronic migraine. And every single one of the studies hit their primary endpoint. And so this is part of what's generating enormous excitement. And there's now been more than 10,000 patients treated with these compounds, so we're getting a pretty good idea about how they work and their safety profile. So again, eptinezumab against the peptide, or what's called the ligand. So it's basically acting as kind of a sponge for the CGRP. It's, again, given intravenously every 3 months. Areniumab, the Amgen product, the differentiating factor is it's targeting the receptor instead of the actual peptide itself. It's given monthly subcutaneously. Amgen was the first one to go to the FDA for migraine prevention. And so that's where it is right now. It's basically in front of the FDA. Fremunizumab is the Teva product. That one's against the peptide. It's monthly. They've also done a Q3 month study, but I think they're going for monthly as their indication. Also submitted to the FDA for migraine prevention. And then finally, galcanezumab, which is the Lilly product. Its CGRP target is CGRP peptide or the ligand. Again, also monthly, also sub-Q, also submitted to the FDA. So these drugs are far along. They're basically currently being evaluated for approval. So just to run through quickly, and I don't want to bore you with a bunch of bar graphs, but just again emphasize the point that every one of these drugs hit their primary endpoint of reduction in migraine days. So this was the eptinezumab study, IV every 3 months, and both 2 doses, 300 milligrams and 100 milligrams, hit statistical significance as endpoints. The areniumab study, this is, again, a different way of representing, but showing that after 6 months, 2 doses of areniumab differentiated with statistical significance from placebo in terms of days per month. Here's the fremunizumab study, where they looked at headache days and migraine days, and again, same sort of graph. And what you're seeing here is also that the results of the studies are looking in many ways quite similar in terms of their effects. And finally, galcanezumab, which also, again, at multiple doses, showed statistically significant separation from placebo. So you look at these graphs, and if you're a migraine person, a lot of these look somewhat similar to drugs that we have already, but there's some key differences. One is they seem to be working very quickly. So within days after administration, even though the studies weren't really designed to look at this, it looks like people are getting better fast, which is something that we haven't really seen as clearly with other preventive medications. And then the other interesting phenomenon is just that there are some people for whom these seem to be very, very, very effective. So there may be a subset of patients for whom this is their thing, where they basically go from significant number of headache days per month to 0 or close to 0, or really very, very dramatic reduction. So those are the kinds of things that have us very excited about this approach. The other thing that's exciting is that it's kind of extraordinary that there have been really no significant adverse effects reported with any of these clinical trials. So there's injection site issues, just with any injectable drug, but there's basically no liver signal like there was with the small molecule. There's no evidence of issues with cardiovascular function. More and more of these studies are coming forward. You may have seen there was a press release just today about the Amgen product and another safety study that they did where they're looking at things like cardiovascular function. So really, that's the other thing that has us very excited, is that these are medications that people seem to be tolerating extremely well, which is not something we can say about most of the other medications that we have for migraine prevention.
So you have another patient clip. So speaking as a patient on behalf of your patient community, what ideas, concepts, or feelings about migraines would patient most like to discuss with their healthcare provider?
I think the only thing that chronic migraine patients are interested in is, how can I live my life? And every treatment option, every conversation needs to be directed around that result of being able to live the life that you want to live.
That is exactly what most migraine patients want. So patient education, open communication with the patient is essential to prepare them to take actions. So you pretty much want to know, when do the migraine occur? You have to ask, and again, this has helped a lot with keeping the headache diary. The patients, typically when you have a migraine, you tend to forget it, it's like childbirth, you don't want to remember it. So, but if the patients write things down in black and white, then you can go back and see what your triggers are, when it occurs, so that you can prevent it if at all possible. Preventative strategies, again, the only way you can prevent something is to know when to expect it. If you know that strong odors, trigger migraine, if you know that red wine, the classic one, dairy, avocado, or, nitrites or whatever, then you know to prevent it. Rescue plans, very important. The last place I want my patients to end up is in the emergency department. So you really want to give them rescue plans, and you want to give them a 1, 2, 3 approach to do when the patients have the migraines, so they don't end up so disabled or in the emergency department. Side effects, again, you want to talk about side effects of medications, how to manage it. What is the red flags or emergency? You definitely need to know that. The patients know what their typical headaches are, but if you have a headache, if you have new neurological symptoms you've never had before, that is something that needs to be pay attention to. Special instructions, travel, pregnancy. When we're flying, the air in the airplanes are very dry. I tell my patients you have to hydrate a lot before you start flying, and when you're flying, you really need to hydrate. I mean, that is also true, not that I want patients know how to drink alcohol, but alcohol is dehydrating, flying is dehydrating, so you really need to stay hydrated, which is one of the main problems why patients get migraines when they're traveling. And also to avoid alcohol while you're flying. Pregnancy, usually what happens with pregnancy, the first trimester is usually the most difficult because the hormone levels are fluctuating wildly. But once you're in the second and third trimester, most people, most migraineurs, their headaches are better after the first trimester of pregnancy. And again, stressful events, biofeedback relaxation techniques, Tai Chi, yoga, any type of relaxation, because no matter what you have, stress just exacerbates everything. Do you have any comments on anything there?
That's good.
So importance of the headache diary, again, it helps recognize, as I said, the migraine attack, the patterns. A typical thing that I have patients do with the diaries is always write down the day a menstrual cycle starts and the day the menstrual cycle ends. And so that we can gauge if the headaches usually start 2 days before the menstrual cycle, if it starts in mid-cycle, so that we can do preventative strategies to help with the menstrual migraines. Warning signs, again, these are all the things that you see in the headache diary, the intensity, the timing, how long do the migraines last, the headaches, and we go from beginning to end. A lot of people, was mentioned before, the premonitory symptoms, yawning. People don't really recognize that as a prodrome, as the migraine starting. When the patients start yawning, or they start having cravings, or the polyuria, in my book, the headache has already started. So patients need to recognize this and to do things to prevent the headache itself, the pain, from starting. So these are all things you have to educate the patients on. And all the symptoms and the triggers are very important. And again, you would know this from the different diary. There are a lot of different diaries on the web. You can find, I don't know, there are at least 100 different diaries. Which one is best or better? I am not really sure. I guess whichever one works for the patient is the better one. Do you have any? Yeah,
I would actually, there's a question of which diary do we recommend. I actually like the electronic diaries the best. We're actually experimenting with a diary where we're actually collecting data also with smartwatches to see if we can identify behavioral and environmental parameters that feed into the diary as well. And just by way of disclosure, I have consulted with one of the electronic diary companies, but the nice thing about those is that they basically prompt people with questions so that it gets people making sure that they're putting down everything that's relevant for them. So I think personally I like the electronic ones if people are able to, if they're technologically adept, which I'm not, but I actually have found that I can use them even despite my technological disabilities.
So knowing the migraine triggers, stress. I don't care what is wrong, stress always makes everything worse. I tell my migraine patients, especially my teenagers and the ones that are in college, you have to, it's a drag, but you have to maintain regular sleeping patterns and regular eating patterns. You go to bed at the same time, you get it at the same time. There is something called like a letdown headache. You're stressed out, you're working. The first day of vacation, you're laying on the top deck of the cruise ship and you come down with a major headache. And when you're not sleeping, when you're sleeping, I should say, you're not breathing as deeply as when you're awake. You're retaining carbon dioxide, which is a potent vasodilator. That can cause headaches. So if you go to bed at the same time, you get up at the same time, if you want to putz around and then go back to sleep later on, but you don't want to on a Saturday, when you get up at 5 o'clock every morning, you don't want to sleep in until 9, 10 o'clock on a Saturday morning, because invariably a lot of patients would then wake up with a migraine. So again, you go to bed at the same time, you get up at the same time. Hormones, we spoke about hormones before. Caffeine is one of the bane of my existence. A lot of commercials and a lot of people tell you caffeine helps treat their headaches. And that is true if you're going to use caffeine once in a blue moon. And I don't know if you know what a blue moon is, but it's a full moon in 2 full moons in a month. And we get that very rarely. But if you're going to use caffeine on a regular basis, it causes rebound headaches. Caffeine is a potent vasoconstrictor. It constricts the blood vessels. And after your last cup of caffeine in the form of Mountain Dew, caffeine, coffee, tea, whatever, the blood levels fall, the blood vessels dilate, and then you get a throbbing headache. You take more caffeine in the form of, over-the-counter caffeine preparations, coffee or whatever, the blood vessels constrict, the headaches go away, and you're in a vicious cycle. So I personally have patients stop caffeine, and I tell them decaf and caffeine-free are not the same thing. Decaf just means less caffeine, but it still has caffeine in it. So I make all my migraine patients caffeine-free patients, and then once I get the headaches under control, if you want to go back to your vices and do whatever you want and the headaches come back, then I give them that blank stare like, okay, so what now? What do you want to do? That type of thing. But I am very strict when it comes to caffeine. I don't know what your feelings are with caffeine.
Yeah, so it would be a little hypocritical for me to be strict with regard to caffeine because I consume a lot of it.
Okay.
I appreciate the point, but my general approach is to say pick your minimum daily dose and keep it consistent as possible from day to day. But I don't necessarily make people withdraw.
Okay. The thing about it, I've had a lot of patients, like I had this husband and wife, and I was seeing her, not him, and I was reading her, the riot act about caffeine, and he was just listening, didn't say anything, and about 6 months later, he came back to me and he said, I want to thank you, and I'm like, well, what's going on? He said, I stopped my nightly chocolate because, as his dessert, and he said he hasn't had a headache since. And I hear that story over and over, so that's maybe the bias that I'm coming to with caffeine. In terms of alcohol, alcohol is dehydrating. So if you're going to drink alcohol, you need to drink a lot of water. You need to drink enough water where you go to the bathroom and urinate 3 or 4 times, and if you don't flush, I don't even know that you're in the bathroom because your urine is that clear. If you don't, that's what I tell patients. So that is the main thing with alcohol. And again, sometimes the red wine is the tannins or the sulfites, the cheaper wine. If you're drinking expensive stuff, you may be less likely to get headaches. Changes in the weather, is not much you can do about it. Maybe move to San Diego, I don't know, but the weather it is what it is. Diets, again, we spoke about skipping meals. You have to be consistent. Dehydration, I mentioned, that's a big, big problem. A lot of patients, when they're just starting to feel a headache, if they really start taking a lot of water in, that can sometimes abort an attack. I've seen that happen with myself and other patients. Light sensitivity, again, patients usually invest in a good pair of sunglasses, odors, cleaning fluids, gasoline. Some women tell me that they tell their husbands they can't clean their house because of the cleaning fumes, and I tend to back them up with a letter. Because, I do. Medication overuse, again, we have the medication overuse headache is a problem. I tell patients routinely, I don't know what your thoughts are, they should not be using acute medications more than 2 times a week. I don't know what your recommendations are for acute medication use.
Yeah, it's a big controversial issue, and there is a question about that which we can get to, but I might as well get to it now. So medication overuse is defined by the ICHD differently depending on the medication being overused. So if it's triptans or opioids or ergotamines, it's 10 days per month, but if it's non-steroidals, they basically then have a few extra days that you can take it. So that's the strict classical definition is 10 days per month. For me, the definition of medication overuse has to do with whether they can go days without taking it. So if they're basically using it, frequently enough that they can't go 2 days without an attack if they're not taking it, then that basically tells me that they're in a pattern of overuse.
So lifestyle changes, controlling the controllable. So migraine hates change, which is what you just mentioned. You have to keep things consistent. And again, it's drag, for the teenager, for the 20-something-year-old, it's somewhat difficult, but again, they have to do the best that they can. Maintain consistent sleep patterns. That is very, very, I can't overemphasize how important that is. If you're going to have caffeine, this says small amounts on a daily basis. I am a caffeine purist, and I say none whatsoever until I control the headaches, and then you can go back. But now, having said this, not every single patient headache is caffeine dependent. So that is not true across the board. Nothing is true 100%. But for a lot of patients, caffeine is a trigger. Don't skip meals, exercise and maintain a healthy weight. Patients with BMI greater than 30 can run the risk of converting episodic migraines to chronic migraines. So maintaining a healthy weight is critical. Managing comorbidities, again, nearly 88% of people with chronic migraines have at least one comorbid condition. 39% have 4 or more comorbid conditions. Again, depression, anxiety, thyroid disease, myofascial pain syndrome, these are all things, neck pain, these are all things that can coexist with migraines. Estimated cost of chronic migraines is $5.4 billion. That's billion with a B in the United States. Addition of comorbid conditions increases the cost of $40 billion. There is also something called presenteeism. So we think of absenteeism, patients missing stuff, missing work, missing activities because of migraines. We also talk about presenteeism. So patients do go to work and they show up, but they're not functioning. You're sitting with your head on the desk, or you're in the bathroom vomiting, or what have you. So you're there, but you're not really there. So that is also something that we take into account when we are talking about disability. 37.2% report comorbid mood and anxiety disorders. Patient-centered care coordination, again, communicate with the neurologist what to expect. So communicate with the neurologist what to expect. What should be done before the referral? Strategies for monitoring, what, how often, who owns the patient? I believe we have a question here. No, that's going back.
Next.
Is that the next? Is that the last slide?
No, we have a question and then some more.
There it is, game on. And the clicker is on delay. Oh, leadership board. The pink team, team pink, hot pink, 170 points. Navy blue, 111, but the yellow, 113. And blue team is approaching. All right, hot pink, let's go. And my clicker is being non-cooperative. Okay, there we go. So what is your expectation when you refer a patient to a neurologist? And I'm actually very interested in this answer. So the neurologist will assume responsibility for the patient, or are you going to receive information related to diagnosis, or are you looking to receive information about drugs, interventions that have been prescribed, or are you recommend what should I be monitoring? So what do you expect when you refer to a neurologist? Please vote now. So most people want to receive information about drug intervention that have been prescribed. Interesting. Okay, so no one really wants us to take over the patient, just maybe 23% of you. Okay.
At least you're not admitting it.
I think we all do.
You all do, but you're not admitting it. All right, fair enough. Next. So tips and tricks from the neurologist. So we were mentioned before to create a template for the electronic medical records of simple checklists that can be used with patients. Tools to use in a time crunch. The ID migraine, which was presented before, is a nice, quick and dirty screening. You can pretty much put it out in your waiting room. I know the patients really don't wait for you. As soon as they show up, you see them right away. But if they're waiting for a minute or so, they can fill out the ID migraine. It does not take a long time, and it really will give you some information as to how disabled the patients are. And I do have a lot of handouts in my office, you know. I do have handouts. I sometimes have paper diaries that I get from different sites, refer patients to different websites to help. Because the more that you educate the patient is the more that they can better help themselves and make your life a lot easier in terms of treating them, so they're not doing things counter to what you're trying to achieve. Any of any?
Yeah, so just a few points. I'm on the board of the American Headache Society, and we're trying to create EPIC templates that basically can be used simply and be able to record data and prompt information from primary care docs as well as neurologists. Other things, the resources, there's a lot out there. There are a lot of websites, some of which have good information, some don't. The American Migraine Foundation website is pretty good. There's also an interesting resource that's happening this week, which is called the Migraine World Summit, which patients can look at for free. And it's basically a series of interviews about specific topics that people can choose to listen to or not. So we're really trying to grow the resources that are out there. But at this point, I do think that it's, there's not a single site that I can recommend that has everything, but probably starting with the American Migraine Foundation website. If I can tout my own organization, that would be one that I would start with.
So SMART goals: specific, measurable, attainable, relevant, timely. Recognize the personal, family, and professional cost of migraines. It's very important that we do that. Apply ID migraine to distinguish migraine from tension and sinus headaches. Some of us do not believe in sinus headaches. I have to agree with you with that, actually. I agree with acute sinusitis, but not sinus headaches. Use headache diary to tease out frequency and severity of attacks. Consider preventive therapy when attacks occur greater than 1 week or 4 or more days per month. And you really need to take in disability into that equation. Educate patients to control the controllable by knowing their triggers and keeping an open line of communication. So we have lots of questions and answers right now, which we'll get to.
So I'll go ahead and start with some. We'll start with the ones that came in earliest, and I'll try and bundle some of them. So there's a number of questions about the CGRP drugs that I'll start with. Well, first there's a question, do you know why the liver toxicity? Again, this seemed to be a small molecule effect related to the metabolism of those drugs, and there hasn't been any liver signal with the antibodies. Are they safe during pregnancy? We absolutely don't know that yet, and so given that their half-life is around a month, it really is important to have the discussion about whether people are planning to get pregnant, because that's something that we just simply have no data and certainly can't endorse having them be given to pregnant women. Do you recommend checking CGRP levels? Well, that's an interesting question. So is there some biomarker that determines whether somebody's going to respond to these drugs? At this point, we don't have any. I have to say the companies, just as I think are at this stage, are happy not to have a biomarker that would necessarily tell us that these are specific patients that we should give the medications to. But that part of the trouble with CGRP levels is, as you remember, they measured them in jugular blood. The compound is very, very labile. And so it's very hard to do reliable assays. So that's something that we're working on, but at this stage we don't have any marker that really is going to clearly indicate who's going to respond to the medication. And then finally, one last one I'll do on the CGRPs and then turn it over to Grace, which is, again, the monthly therapeutic efficacy. So, basically most of the studies showed a reduction of the primary endpoint was, again, a statistically significant separation from placebo. So typically there was 5 to 7 days less of headache per month, although for some of the medications they've shown even better responses in subsets of patients. And it separated from placebo, really not that, not by a huge amount, typically by 1 or 2 days per month better than placebo. But that's actually, I think, again, fairly typical of clinical trial designs. So, it really is, I would just have to say again, also the subsets of patients for whom these are really, really effective, and the tolerability and the specificity that has us most excited about them.
There are a few questions about cannabis and marijuana. I'm going to address that. I am a big proponent of cannabis for migraines. It does help. The cannabis plant has about 420 something ingredients in it. Of the 420 plus ingredients, about 70 of those are active ingredients. But when people think of marijuana, they just think of one ingredient, and that is THC. THC is one of 400 plus ingredients in the plant. For migraine prevention, the part of the plant that is really effective is cannabidiol, the CBD part of it, not so much the THC part of it. So CBD dominant products are used as preventative for migraines. Then now, a lot of people talk about cannabis hyperemesis syndrome. The cannabis hyperemesis syndrome in chronic cannabis users, they get this repeated vomiting, but that is people who are using THC high product on a regular basis, and then they get a cyclical vomiting. You take hot showers, and that's one of the treatment for it, besides stopping the medication. So that is not what we use to preventative for migraines. If you have an acute migraine attack, you do need something a little bit higher on the THC side to treat it. But for prevention, it's the CBD part of it, which does not have any psychoactive effects and which does not have the cyclical vomiting effect. And that is what I use to treat my migraine patients with very good success. I trained in California. Cannabis was legal in California in November 1996. When I moved to New York in 1997, I couldn't use it until it became legal in New York in January of 2016, when I've been prescribing it ever since with good relief. I don't know what your take is on cannabis.
Yeah, so I'm a little bit more of a skeptic, and not for any particular moral, ethical reasons. It really is just remain unconvinced by the evidence. And it's partly, to be clear, it's the reason we don't have evidence is because we couldn't get the compounds to use in our laboratory to try it out because it was illegal. They were basically banned because of their scheduling. So I'm very interested in the possibility that cannabinoids could work. My concern about them is the possibility of medication overuse, given the similarity of cannabinoids to opioids. And that in the long run there may be those issues. I will notice, I actually saw just this morning that a CBD product looked like it's getting the green light for treatment of epilepsy, where the evidence is really pretty good. And so now that we are going to have potentially approved CBD drugs available, I think it's going to behoove us to really do the kinds of studies to see if you're right.
Well, I know I'm right, but
Yeah.
but just one more point.
Yeah.
The reason why cannabis is illegal in the United States is all politics. If you look at the pharmacopoeia of the United States, it was legal in the United States, and one of the things that it was used to treat is opioid addiction. So even though there is some of the receptors used by both, it is really not on the same level as opioids. There's another question here about acupuncture. I'm a licensed acupuncturist myself, and the entire body is mapped out on the ear. So there are a lot of different piercings and points in the ear that can be used to treat migraines. And again, nothing's 100%, but some patients do get relief from certain points in the ear when you pierce. The tragus is one of them, and certain points in the pinna that patients do get relief when they do that from their chronic migraines, and they just throw the earring or whatever stuff they have there that helps treat a migraine attack or abort one when it's happening. Do you have any experience with that?
Yeah, now that one I'm going to have to disagree with you about. I'm skeptical, entirely skeptical about that. Although, having said that, I think migraine is something where we have to keep an open mind. And what I tell patients is, if it's not too expensive and if it's not going to harm you, then I'm not going to stand in your way in terms of wanting to try something. So the trouble with many therapies for migraine, and the other thing that's out there that there's no questions about it, but there have been all these centers proliferating at doing migraine surgeries. So reducing contact points in the sinus or decompressing occipital or supraorbital nerves. And here's a case where really people are just exploiting the desperation of migraine patients and charging enormous amounts of money to do things for which there's really absolutely zero evidence. Somebody asked about the dose of candesartan. So the clinical trials looked at 16 milligrams a day. I typically start people on 8 and then go up to 16 after 2 weeks or a month. if they're tolerating it okay, which most of them generally do. Question about evidence for TMS. So the TMS that we're talking about is single pulse TMS. It's a handheld device that you basically give pulses to the back of your head. There was a randomized placebo-controlled study for acute therapy of migraine. That was how it was originally indicated, and then there was a follow-up observational study that was just published this year that showed benefit in terms of prevention as well. So, so the evidence for acute treatment is good. The evidence for preventive therapy is not as high quality, but it's still reasonable. An interesting thing about the devices is the FDA's standard for evidence for devices is much, much lower than it is for medications. So that hence, Cephaly and TMS and other devices that are basically in development, they have a lower bar to clear than medications do. Any you want to answer? Here's what about aura without headache? So migraine aura without headache is very common, especially in older folks. If it's frequent and disabling, we institute preventive therapy. Interestingly, I'm very, very interested now in the connection between patent foramen ovale and migraine with aura. We just published a study in the American College of Cardiology journal on the latest PFO closure study for migraine, which was basically negative. But the story's still not dead yet, and the interesting thing is that for patients who had aura with the majority of their attacks, that subset of patients had a very significantly positive response to PFO closure. So there's growing interest in the possibility that PFO closure, or that the PFO is actually also potentially the link between migraine and stroke. So migraine, the risk of stroke is higher, especially in young women, associated maybe with oral contraceptives. So the idea is not that it's migrainous infarction where stroke is happening as a consequence of the migraine attack, but rather there are parallel risk factors for stroke and for migraine, and that might be a much better way of actually explaining that.
There was a question I'd asked, can you use onabotulinum toxin as a preventative? That is the way that you use onabotulinum toxin, is to prevent migraines. Again, the criteria is patients who have 15 plus days of headaches, and the patients have to last at least 4 hours. And for insurance purposes, they've tried and failed 2 preventative medications. And then the patients can get the onabotulinum toxin as a prevention to decrease the frequency, severity, and duration of the migraine attacks. There was another question also about, in terms of triggers, what do you cut out everything at once? And it depends on what the patient is doing. You can cut out one thing at a time, so dairy. I don't know, there's some people that are very sensitive to dairy, so I would have them cut out dairy for a while and see what happens. I would have them do it for about a month. I don't know what you do. And then reintroduce it and see what happens. Or citrus is another one that can cause migraines for some folks, or the nitrites and things like that, and see what's, if that indeed caused the headaches. It's a little bit tricky with the foods because, again, more than one thing could be causing the headache. So it's sort of tricky with the foods, but you do one thing at a time. And also, if something is a trigger, shortly after you consume it in terms of food, it doesn't take days before the headache comes on. If I'm truly sensitive to something, within hours of me eating it or drinking it, I will indeed get a headache. So sometimes it's, if you really pay attention and in tune, you can figure it out.
Yep, so I'm going to go off the rail here a little bit and say something totally heretical, which the headache community hates me when I say this, but for all the time we end up talking to patients about triggers, we just almost never find people who the percentage of patients at least who get to my practice who find something, one or two things that really is the key to their migraine is very, very small. And again, I'm not telling people don't look for them, don't avoid them, but I don't spend a huge amount of time on individual triggers like gluten or dairy or anything, but just say, look, just focus on consistency. Eat regularly, sleep regularly, exercise regularly, have a balanced diet. And my other point about the trigger thing is that many patients will then just be fixated on sort of blaming themselves if they have a migraine attack. They'll say, well, what did I do to bring this on? And most of the times the answer is nothing. It just happens. Migraine happens. There's not always a cause that you can identify. And removing that sort of sense of blame is often very liberating for patients, where they don't have to feel like they're constantly looking back to see and sort of actually, again, blaming themselves for something that was out of their control.
There's a question here about how long do you use preventative medication? And my rule of thumb is I use the preventative medication until the headaches come under control. So if the patients are having 15, 20 headaches a month, they're now on preventative medication and they're having headaches now maybe once a month, once every 2 months. I then keep them on the medication for another at least 6 to 12 months because I really want to make sure that things are settled in. So the day you start feeling better is not the day that I say, okay, you can stop the medication, which is what patients are prone to do. So I keep them on the medication, usually for another 6 months, and then we slowly start to come off the medication. That is the strategy that I usually employ. And the other question they ask, and I'll turn it over to you, about gabapentin. Gabapentin is a wonderful medication to treat neuropathic pain and different pain states. I also do pain management. But in terms of treating migraines, I really haven't had that great success using gabapentin.
Yeah, agreed. So a couple more questions and then we'll wrap up. So actually just quickly about that duration of treatment. When I start a preventive therapy with migraine patients, I make clear to them, I'm not saying that you need to be on this for the rest of your life. Very often if you can just get somebody to a new equilibrium, including doing some of the lifestyle stuff and better acute therapies, then you can withdraw the preventive medication and they get along just fine. So there's a fascinating study with topiramate where they treated people for 3 months or 6 months, and the people and looked at 6 months, and at 6 months, the people who were on it for 3 months were doing just as well as those who stayed on it for the full 6 months. So it may well be that we're leaving people on medications more than we need to. Quick question, how do you treat, this is not a quick one actually, admitted to the hospital with severe migraine? There's no universal protocol. We use intravenous dihydroergotamine. In the emergency department though, the ER docs really like phenothiazines, so prochlorperazine, as in particular, some even use thorazine. There's actually evidence for that. Whether or not they're really helping or just basically snowing people and making them not complain isn't clear, but certainly there is evidence that dopamine is playing a role, and so the ER docs really like the phenothiazines. The one thing that we use a lot, which is controversial, is actually steroids. There is actually a pretty good ER study showing that a dose of dexamethasone intravenously really significantly reduces the rate of people coming back to the ER. And we use actually oral dexamethasone in a very short course as a acute or as a sort of a short-term crisis approach in people who are having status migrainosus or simply can't get out of an attack. I don't know if you use
I also like ketorolac. I use a lot of ketorolac and also with some Reglan too. I find that it's very helpful.
Yep. So I think we're just about out of time here. I'm sorry if we've missed some of your questions, but we can...
there was one more question about bruxism, and a lot of people grind their teeth, and I can tell because when I look in their mouth, their teeth are chiseled down or what have you. And so I do send people for appliances, the TMJ specialist. I do some, injections into the masseter and temporalis muscles, but bruxism is a cause usually of early morning headaches. I find that along with snoring. Those are so 2 causes I find of early morning headaches, bruxism and snoring.
Yeah, there's actually, you were mentioning CO2 before. There's a recent study out of Scandinavia where they actually increase CO2 levels and make people slightly hypoxic, and which they can do, I guess, in Europe, but that also triggers migraine. So there's actually a scientific basis for understanding how sleep apnea might actually be playing a significant role. Okay, well, really appreciate your
Thank
attention.
you.